There is no specific area where it is concerned with consciousness. The entire brainstem and the cortex, the integrity of it is required for maintaining of consciousness. Now this is like an umbrella. You see, the stem is important, the razors are important, the ribs are important, and the canopy is important. The stem represents the brain stem, and the razors, the reticular activating, the connections from the brain stem into the cortex, and the canopy is the cortex with the ribs. So if any of these is defective, the umbrella is dysfunctional. So similarly, if there is a disturbance in any of these sites, patients can have changes in sensorium. Now, don't be worried, there are just 3 causes for unconsciousness. Simplest way, it is either metabolic or toxic. That means there is no structural lesion in the brain, or there is a structural lesion either in the cerebral hemisphere or in the brain stem, that is in the stem or in the canopy. Or it could be meningeal because it has coverings, and then meningeal pathologies also can produce change in sensorium. Now, where the brain is structurally normal, the toxins are perfused from the blood because of dysfunction of some other organ like renal failure or uremia, hypoglycemia, hyperosmolar. These are all the things that can affect where there is no structural lesion in the brain, but patient will be unconscious. A few videos. Cyanosis, you know, it's airway obstruction. Jaundice, you're likely to miss in artificial light, so think about it and send bilirubin. Then petechine, hemorrhages, IV needle marks, these are all routine things. But one thing, eschars like this, scrub typhus, you're likely to miss if you don't make a good physical examination of the skin. They are likely to be in the gluteal folds or in the axilla. If you find an eschar like this, you're dealing with scrub typhus. A very slow heart rate, you know, it's a heart block. Periodic breathing with hypertension, you know, patient has got evidence of increased intracranial pressure. Now hypertension, it's either hypertensive encephalopathy or an ICH or increased ICP due to a tumor. Now hypotension, CASH, you remember this, CASH, nobody can forget, cardiogenic, anaphylactic or Addison's, septicemia, hypovolemic or hemorrhagic. So if you find a patient hypotensive and then unconscious, first deal these things first. The types of breathing. You know, chain strokes breathing, waxing and waning, that's very typical. Then shallow regular breathing is because of drugs. Deep rapid breathing, metabolic acidosis, pneumonia, but a neurological condition which mimics deep rapid breathing is central neurogenic hypoventilation. Now temperature. Source of fever can be intracranial or extracranial. Elderly patients, extremes of age, patients have a systemic infection, urinary tract infection, they come in altered sensorium. So just because there is fever and altered sensorium, don't think it is meningitis. Okay, now you assess the patient. I will not go through the Glasgow Coma Scale and all for paucity of, for the time. Then assess the level of consciousness by that. Then look for external signs of head injury if the patient is brought by some onlooker there is no family member. Pupils and fundus and all we'll see on the videos. And look, meningeal signs and doll's eye movements. One thing, make sure that there is no neck injury when you do all this, when meningeal signs and doll's eye maneuver. When you observe the patient, if the patient is having some spontaneous movements only on one side, then you know you don't require a rocket scientist's brain to say he's hemiplegic on the other side. But on the side which is moving, if there is abduction at the shoulder, you give him a painful stimulus on the arm, and if he abducts the shoulder, that means that side is not paralytic. If somebody can abduct at the shoulder, that means there is no deficit on that limb. Decortication is when the upper limbs go like this towards the heart. Cord is heart. Decortication. Decerebration we will see. So that kind of extension is decerebration, a very important thing, that there is raised pressure and you have to act immediately. Somebody who's come with an unconscious state with a leg outturned like this, then you know either it should be a fracture femur or it should be a hemiplegia on the left side. Glasgow Coma Scale, we will run through this. Fundus examination will be helpful in certain situations like hypertensive changes, papilledema, hemorrhage, and subhyaloid hemorrhage indicates a subarachnoid hemorrhage. Now small pupils, we all know in agricultural country, we have small pupils, organophosphorus. Narcotics, okay, we do see. Now look at this. What do you find in this? One pupil is larger on the right, smaller on the left, and there is mild abduction. So it indicates that the patient has a right third nerve palsy. Now what is the importance? Our examination should look for a localizing lesion, whether it is brainstem or cerebral. So for cerebral, we know we have hemiplegia or some of the signs, but for brainstem is important because and how do you examine brainstem? Just by doing two simple maneuvers. Looking at the doll's eye. You need the third nerve is situated in the midbrain, and the sixth nerve nucleus is situated in the pons. So there is a mechanism, fortunately you don't require full alertness and cooperation of the patient to see these two cranial nerves. You have a maneuver called doll's eye maneuver, which is an inbuilt mechanism in the brain where when the head is turned to one side, the eyes will move to the opposite side if you are unconscious. But because you are conscious, you will fixate, so they will not move to the opposite side. You make use of this and to see whether the third and sixth nerve are intact. If they are damaged, that means the brainstem is gone. If they are intact, the brainstem is intact, and therefore you look for a cerebral cause. Now look at this video. What do you find? The picture. What do you find? The eyes are not at the same level. This left eye is down, isn't it? So this is skew deviation. So this indicates either the left eye is down, so it is a right thalamic problem, usually a hemorrhage, or a left lateral medullary problem. So either way, it is compressing on the upper brainstem. So this is skew deviation of the eye. You will find most of the patients, if you see thalamic hemorrhage, next time you go and look, you will find this. Then roving eye movements. Now the eye movements, we have several things that we will see on videos. If somebody has spontaneously, the eyes are moving in both directions. This is what happens when there is a mild cerebral insult. A patient has been resuscitated after a cardiac arrest. He will have to and fro movements like a windscreen wiper. That means this says that the brainstem is intact because the patient is able to abduct the eye and adduct the eye, so the brainstem is okay. You don't have to worry much. You think about only the cerebral causes. Sometimes patients come with an unconsciousness which looks like a metabolic problem, but it is actually a stroke. Artery of Purkinje. This Purkinje artery supplies both the thalami, and it is a single artery where if it is knocked off, patients can be unconscious. It looks like a metabolic problem, but the clue is an upward gaze palsy will be there. Look at this video. The eyes are going down slowly and bouncing back. This is ocular dipping. This is usually seen after. So the better picture is the roving eye movements. A little worse picture is this, ocular dipping. There is significant supratentorial insult and you have this ocular dip slowly and then bounces back. This is ocular dipping, and intact doll's eye movements. The doll's eye movements are present in this. That means it is much better than the other patient. The another patient dipping will run through. So he's getting myoclonic jerks. Another insult after hypoxia. This is another picture that you can get. Doll's eye movements will be there, but this is usually myoclonus, and seizures indicate significant cerebral insult. Patient is confused, incoherent, and look at those jerky movements. An alcoholic, what is the diagnosis? Delirium. Now, what is the importance? How do you look for doll's eye movements? Now this patient has got eyes to the left. It is a supratentorial lesion. Patient is looking to the left. In cerebral hemispherical lesions, the eyes will be towards the lesion. So you look at the patient's eyes, it will tell you, hey, I've got a lesion on the left side, right side hemiplegia. Now, but how do you know that the sixth nerve and third nerve are intact? Because the eyes are to that side. So this is what helps you. This test will tell you that the brainstem is intact. When you move the eyes, when you move the head, the eyes will move to the extreme right. Oh my God. See that? The right eye has reached the right extreme, right? So that means that there is no right sixth nerve palsy in this patient. That is the ocular dipping is the one, and this is the worst. What is happening? In contrast to the earlier lady which I have shown you, the eyes are not moving to the extremes. That means the brainstem is gone. It's a very bad prognostic sign. The brainstem is injured. Now, more powerful stimulus than doll's eye is the caloric test. Now this patient had a doll's eye, the right eye was not abducting. This is a case of snake bite. He had some hemorrhages and hypoxia. Now while I'm irrigating the right ear, you see the right eye deviates to the ear. That means the brainstem is intact because caloric stimulation is more powerful response than the doll's eye. So you're able to get it. So this is an intact brainstem, but he did not have a Dolce, but on caloric responses, there was a good response. Similarly, irrigating in the left ear, but the left eye is not abducting. The left eye should go to the left. This is in an patient with unconsciousness or altered sensorium. In a conscious patient, if you do this, you will get nystagmus, because the eyes, cold water will stimulate the eyes towards the same side, the mnemonic cows,
5 more minutes,
cold opposites. See that? This is a bad prognostic sign. That was ocular dipping, this is ocular bobbing. Now this is all the, now you can have a patient, usually EEG is very high amplitude, slow waves in an unconscious patient. But you can get a normal looking EEG like this, and it is called alpha coma. So just don't go by the EEG. Sometimes the patient is deeply unconscious, but your EEG can be normal, like looking like this. Now management, gastric lavage, intake organ, all these things are there. Now, what is the importance? You have somebody who has come like this, no localizing signs, you find deeply comatose, no meningeal signs, the CT scan, you had seen the earlier session on CT scan. What is the diagnosis? Subarachnoid hemorrhage. There is all blood in the cisterns. Now this is a patient where fever, altered sensorium, you find mild, faint, hyper involvement, swelling of the thalami. This happens with Japanese encephalitis and cerebral malaria. If you have a picture like this, think of these two conditions. Bilateral subdural. Patient just will be unconscious, and if you do a CT scan, it's very helpful. Now you have what is called a non-convulsive status. Patient is unconscious, you don't find your MRI is normal, CT is normal, you think of the CSF is normal, patient is having seizures continuously. So think of non-convulsive status epilepticus. Then when you give glucose, don't forget about thiamine in patients who are alcoholics particularly. Hyponatremia is one thing that you have to correct, and then don't be very enthusiastic to correct hyponatremia. This patient came with a sodium of 102. Our residents gave the 3% saline, then by next day morning he was 115. He was all right for a day. On third day he became unconscious, and then we were scratching our brains. Then he has got osmotic demyelination in the pons, CPM and other things. So these are the things that you have to be careful. So don't correct hyponatremia greater than 8 milliequivalents in 24 hours. So keep repeating it, because your infusion rate you can adjust and then slow it down. The other thing that I wanted to tell you is, pre-existing mild strokes, patient is ambulatory, he has recovered very well, but for some reason he is unconscious due to metabolic encephalopathy or after anesthesia. You may find those limbs slightly weaker, and you might mistake it for a fresh hemiplegia. Think about it. Then the other thing is, I told you Dolce movements absent, patient unconscious, I told you brainstem, right? But if the pupils are okay, if the pupils are of normal size, then it is invariably due to a sedative hypnotic drug poisoning. You can give flumazenil, the patient will sit up. So Dolce movements absent, no response, patient is on ventilator, but still the pupils are normal, then think of drug coma. Osmolarity. Then one word about Lockton syndrome. Here the patient appears unconscious, but is fully conscious. All the mechanisms for him to express the cranial nerve muscles, the limb muscles are paralyzed due to a lesion in the pons. The only movement that is possible in these patients is vertical eye movements. If you don't test vertical eye movements in nobody does that. In an unconscious patient, you will think he's unconscious, but just say, look up. If he can move the eyes vertically, that means he is in Lockton syndrome. He is aware of everything. He can hear every word of what you say. He can understand everything. But you will think he's unconscious. So this is Lockton syndrome. So be careful when you prognosticate this. Anyway, it has got a bad prognosis, but he's conscious and he's aware of everything. So vertical gaze you should look for. Persistent vegetative state is what you see in patients that nurse in Bombay, 20 years unconscious, fed on Ryle's tube. Both cortex is damaged, patient is alive because the brainstem is functioning. So they have sleep-wake cycles, but they don't make recognition, they don't recognize, they don't communicate. So that is persistent vegetative state. So summarizing the whole thing, if you have 3 causes, I said, no focal signs, you don't find hemiplegia. The brainstem is intact, then everything is okay. CT scan and MRI is usually normal, so then you will think of these causes: metabolic, systemic infection, hypertension, encephalopathy, concussion, heat stroke, hypothermia, shock, and all these things. These would be the causes if the brainstem is intact on your examination, the dolls eye are good, patient is unconscious. Now, if you have meningeal signs or if the CSF is abnormal, then you know it's a meningitis or meningoencephalitis or subarachnoid hemorrhage. Now, you have focal signs, obviously your MRI or CT is going to show you a focal lesion, it may be either cerebral or hemisphere. So if somebody does not have a deficit, think of metabolic and toxic causes. Somebody has a meningeal sign, think of meningeal causes. Somebody has a focal deficit, then it's obvious it is a structural lesion. So, no focal signs, no meningeal signs, metabolic, drugs and systemic causes. Meningeal signs, it can be infection or subarachnoid hemorrhage, and there are focal signs, then it is a structural lesion. So, it's very simple and easy. Thank you.
That's an excellent talk about what do you need to think when you see an unconscious patient, right? And as emergency physicians, we like a mnemonic ABC, but there is something else, DFG, don't forget glucose. Don't forget glucose in unconscious patient, okay?
Sir, I have a question, sir. This is fantastic as long as there is genuinely a problem with the patient. But quite often in the emergency, we see patients who are psychosomatic, functional is what we call. They keep collapsing, young girls, young boys in hostels. So what would be your few examination findings before going for a scan or something?
It is always safer to exclude even in a functional patient, because on follow-up we find that these patients do develop sometimes, because after all thought process is from the brain and they are thinking abnormally. So I am the last person to say this is functional and without investigation. It's always safer to do, but in my heart I know, okay, nothing to worry, I don't have to worry, I won't get a call this night from this lady, because even if it comes I know what I'm dealing with. But it is, that problem is because they don't make a good examination and observe the patient without her knowledge on the stealth, and then you will know that the patient, if there is nobody in the room, or they will do their routine activity wonderfully.
So close the curtains and let them be alone. Send the attendants out.
Sorry?
Ensure. I think we should ensure. I mean, quite often we see that, they are attracting. Attention seeking is always there.
Yeah.
So we leave the patient alone. We ask the attendants to wait outside and watch them from a distance.
Yeah. One way is to send away all the attendants and then observe, because the attendants are there, they continue to do it. And then if you are there, when the doctor comes, when the sister comes, only they do it. Otherwise you just feed them and then stay away, you observe them, it's quite easy. If it is a child, I use something, I threaten them. If you don't recover after this injection or something, I will strip you, you'll have to strip naked. If it's a child, I sometimes threaten them with that, and then they do that. And then I use tuning fork and various things. I tell them, I excite the tuning fork and put it on a place and tell, if you don't move your hand, and this is electricity going into the brain, if you don't move with this electricity, I'll have to shave your head, put wires in your brain, and then deliver electric shock. And then invariably, I am successful with this.
Thank you, sir.